Okay, so welcome again to this another session in anatomy. I'm Dr. Ankit, your faculty in anatomy in our Auricle platform, and we are into this quick revision series and 21-day Auricle series. And we had done with few sessions. Today we are going to begin with the session on the thorax. Thorax we had divided into two sessions, first and second. First is today, and the second will take on probably tomorrow. Let's see what are the topics that we are going to discuss. But before that, let me just introduce you guys to the Auricle. Here are some of the points or some of the salient features why one should choose Auricle. Let us see the foundational classes over here, the live classes. We have the express exam, doubt clearing, hard copy notes, Q bank, and even the practical sessions as well. These are all the subscription plans, and I urge all of you to just go through it. Even you can take the screenshot of it, and you can share with your friends, and let them get aware. And this is the code that you can use for its discounts. So talking about the plans, we have from 3-month plan to around 6-month to a complete year up till the 4 years. And these are all the features that you get. Just remember that the last two features over here, the hard copy note set and the one-to-one doubt clearing sessions, are available for these two plans, 12 months and 4 years. Okay. Others are common, like pre-recorded classes, live classes, express exam, practical sessions, Q bank. These are common. So yeah, these are subscription plans. Just let your friends also know. Then let's come back to our topic, that is the thorax. And today being the first session on thorax, let us see what we have in store. Okay, so let's proceed. So thorax part 1. A few sample questions that you can see over here, or that will define what how is the session going to take its course. Question over here is a long essay question. Provide a comprehensive description of the anatomy of the thoracic wall over here. So question is regarding thoracic wall and the structures contained within the thoracic cavity, highlighting their interrelationships and clinical implications. Okay, so basically the anatomy of the thoracic wall and the structures inside the cavity and the heart, lungs, and the mediastinum basically. Other set of questions can be describe the features and function of the diaphragm as a principal muscle of respiration, basically the anatomy of diaphragm. Then explain the role of thoracic vertebrae and ribs in protecting the thoracic organs and in respiratory movements. So it's a sort of overlapping topic in physiology as well. But here we discuss about the vertebrae and ribs for respiratory movements, basically the joints in the thoracic cage. Then this question can come as a describe the structure and function of the pleura, including the spaces and the clinical significance that we'll see. Then here we describe what is the role of intercostal muscles, that comes as the intercostal spaces. Define about this or describe about the sternal angle or the angle of Louis, and explain the clinical significance of the costo-diaphragmatic recesses that comes in under the pleura. Okay, so what do we get from here? What are the topics that we should be touching on? Let us see. So thoracic wall is what we should be touching on. Okay, that will include the intercostal spaces. Okay, that will include the vertebrae, the bit of ribs, a bit of the joints in the thoracic wall, a little bit top of the sternum, and that also includes the sternal angle. Okay, with the sternum, it also includes the sternal angle. Then we have to talk about the pleura. Okay, which will include the basic types of pleura, their importance, and also about the various recesses. Okay, that basically helps in respiration. Apart from this, we also have to talk of the bit of diaphragm, as the question might come from here. Which diaphragm? Basically the thoraco-abdominal diaphragm. Okay, so these are all the topics that we'll try to touch upon in this particular today's session. I hope you be with me and make your own notes. Any queries, let us know in the comment box or later on, so that we can see about it, what we can do. Okay, so these are all the topics. Let's start with the basic thorax of the thoracic wall. Okay, let me just 1 second open up over here. Just 1 second, guys. So first topic that we are going to start is the thoracic wall over here. Okay, which will include all the things that we already have discussed. Right. Okay. Okay. Just open up the comment box so that if you have any comments, do type over here so that you can go through it. So what is thorax? What is thorax over here? Thorax is nothing but a part of trunk about the thoracic diaphragm. So basically, this is very straightforward, but we should know that in the body we have a head and neck, and we have this whole trunk part, and these are the upper limbs and the lower limbs which are going downwards. Now, in the whole trunk part, we have this diaphragm which is situated in between. Above the diaphragm, we have the th dot thorax, and below the diaphragm, we have the ABD, that is the abdomen. Okay, so what they're saying is a part of the trunk above the thoracic diaphragm. So this hole is the trunk, and the part above the thoracic diaphragm is the thorax. Simple. Now, let me use a highlighter over here so that we can go and discuss everything. Thorax has basically two principal organs. One is for the respiration, that is the lungs, and one is for the circulation, that is the heart. And both are vital for living. Okay, in contrast to the upper and lower limb, which are essential but not vital. These both are vital. It has a skeletal framework, the thoracic cage that we'll see, and that is covered with the muscles of upper limb. So some muscles of the upper limb also cover up the thoracic cage. Can you guys name which muscles? Which muscles of upper limb can or do cover the thoracic cage also? Those muscles to begin with, P major, pectoralis major. Okay. Then we also talk of serratus anterior. Yes or no? Then we talk of pectoralis minor. Even we talk of trapezius. These are all what? These are all basically muscles of upper limb, which are actually sort of covering the thoracic wall or thoracic cage, because the upper limb has to move. So remember that. Thoracic cage over here is a image of thoracic cage. Even you can draw it, that is not very difficult to draw. But understand, these are the in today's session I have few notes written so that it will give you an idea of how to proceed. You can actually expand that in your main exam depending on the questions, the number. It is 5 marks or 10 marks question. So thoracic cage, it's a osteocartilaginous conical cavity. Why conical? Because the upper part is small and the lower part is huge. Upper part is normally known as the inlet of thorax. Lower part is normally known as the outlet. We'll see. So it's an osteocartilaginous. Why we say osteocartilaginous? Because osteo means it has the bones, as you can see, and this bluish color, the light blue color, that is all our hyaline cartilage. So that is hyaline cartilage. So we call it as a osteocartilaginous. It is shaped like a truncated cone, as I already described. Truncated cone. Upper opening is narrower than the lower opening. Okay, this is the upper opening, and below this is the lower opening. Okay, now sir, how to make it? It's very simple. Just you have to know what are the various things over here. So you can start with drawing the sternum in front, okay, and a bit of the thoracic vertebrae behind, and then between them you can just arrange few of the ribs over here and a costal margin over here. But don't forget to draw this costal margin also, right? So you have a nutshell idea, okay, in the exam hall, how just to make the thoracic cage. So these few things you can start writing. It's a osteocartilaginous conical cavity with truncated cone, and about the upper and the lower opening. Just a slide over here to show you the basic differences between the thoracic cavity of a human being and a quadruped. Quadruped means four-legged animals. Humans over here are bipedal. We are all bipedal, that is walking on two legs. So you can see over here that in humans, the transverse diameter is more than the AP diameter. This is anterior-posterior diameter. While in quadrupeds, because all the time they are, it's with the gravity and it's with the force working downwards, their AP diameter over here is more than the transverse diameter. Okay, here transverse is more than the AP diameter, right? You can see over here, understand. Just imagine some quadrupedal animal, four-legged animal, be it a dogs, be it cat, be it cows, be it buffalo animal. You'll imagine with this diameter part over here. Now, this is also important about the vertebrae. About the vertebrae over here. Here, the entire vertebral column is being shown to you. This image is a anterior view. This image is a lateral view. This image is a posterior view. The curvatures can only be understood best in the lateral view. So this is the lateral view. In the lateral view, remember that this is the anterior side. This is the posterior side. Why? Because the spines, they are facing posteriorly. So spines are placed posteriorly. If you look at the thoracic part, let me highlight over here. This is the thoracic part over here. Here, what you will see that anteriorly it is concave. Anteriorly it is con dot concave, conc concave, and posteriorly you can see it is conv convex. Okay, so anterior concave means it provides more space for the lungs and the heart. Anteriorly, because this is where the cavity lies. Anteriorly is where the cavity will lie. So understand this. And this normal curvature, technically or medically, what we can call it as, we normally call it as a kyphosis. Kyphosis about the thoracic, and if you go look below, then also about the sacral vertebrae. Okay. In contrast to this, you can see this is cervical and the lumbar vertebrae. They are anteriorly, they are convex. So that is known as lordosis. that is known as lordosis. It refers to cervical vertebrae and the lumbar vertebrae. So remember, kyphosis, lordosis, that is normal. But if it is exaggerated, if it is too much, then becomes hyperkyphosis, hyperlordosis. Then there is some issue. If there is a lateral bending to the entire vertebral column, lateral bending, then what it is called as, this is all applied anatomy, which I'm telling you side by side, so that you can use that in your answer writing or in Viva also. The side by side anyway is bending. It will be known as scoliosis. Scoliosis. So just remember about the thoracic vertebrae, and not just thoracic, but the entire vertebral column. Sternum over here, a slide about the sternum. Here you can see the sternum has three parts. You can simply in exam hall, you can make it by this manubrium, the entire body, and a small piece below is the xiphoid process. Then you can slightly elaborate, okay, it is somewhat like this. The ribs are attached and the clavicle gets attached. Here you can make some lateral facets over here. Below you can make this xiphoid process. Then you can understand with that this part is known as manubrium. Let me use a highlighter over here. The manubrium over here. This part, the larger part, is known as the body, and below is the xiphoid process at the lower down. Now, what is attached where? Technically, you should know that in the manubrium is attached the clavicle and the first rib. And then the second rib is attached at the junction of what? Manubrium body. That is the most important part. Where does the second rib actually attach? And it is not the rib, it is basically the second rib costal cartilage. Why? Because this junction of the manubrium to the body is known as sternal angle. That is in itself a separate question, as you must have seen. So sternal angle, or the angle of Louis, gives attachment to the costal cartilage of the second rib. Then you have around lower down, you have the seventh costal cartilage that is attached. So lower down you will see over here, the last costal cartilage to be attached is the seventh over here. Then 8th, 9th, 10th, they are attached below the 7th. 8th, 9th, and 10th are attached below the 7th. They form the costal margin. 8th, 9th, 10th, they form the costal margin. This thing should be very clear in your mind, guys. Most important over here, you should know a couple of things. Let me just highlight what are those couple of things. First thing that you should know is basically the parts of the sternum and how many ribs are attached to it. Second thing, you should be crystal clear about the location of the sternal angle and which rib is attached over here. Second, simple as that. Okay, let's move forward. Here, 2-3 things are shown just for your table. Just can note it down. What is jugular notch? It is also known as a suprasternal notch. What is it known as? Suprasternal notch. What is this, sir? This is the, if I try to again make the manubrium over here and the body below, okay, and the xiphoid process over here, then this level, this is known as jugular notch, and it is not at the upper part of T1 vertebrae, but behind. If I try to make over here, and be with me for a few more seconds to understand. If you understand, then behind, if I make a vertebrae, because until you will have the body of vertebrae, right? So you have T1 over here, then a bit of intervertebral disc, and you will have a T2 over here. So this vertebrae is T1 body. This is the body of T2 vertebrae. So this jugular notch, this is known as suprasternal or the jugular notch. It lies in the disc between T2 and T3, because at over here you will have the intervertebral disc between T2 and T3. So this point should be clear. Second point, sternal angle. What is sternal angle? This is sternal angle. It lies between disc T4, T5. So just imagine behind you have this over here as T3 and this over here as, imagine, T4. So this sternal angle will lie between the disc T4, T5. So, but sir, why is that information important? Just for passing exams? No. They are important for you, basically. CTs, MRIs, X-rays. They are very important. Okay. Then the free sternal joint over here, this refers to behind around T9 or the 9th thoracic vertebrae. So we have 4 over here, 5, 6, 7, 8, and the 9th over here. Okay, so do remember this. These are 3 basic vertebral levels. Now, same information, previous information, let us correlate over here with this image. This is our first vertebrae, thoracic vertebrae. This is T2. This is the jugular notch. What is this? Jugular notch. Okay, then we have the T3 over here, we have the T4 over here, and this is the sternal angle. Then we have 5 over here, 6 over here, 7 over here, 8 over here, and 9th over here. Okay, understood? 9th, and then you will have the 10th, and then the 11th, and the 12th, 10th over here, 11th, 12th over here, Just a second. Yeah, just 1 second. 10th will be your 11th. 12th is this, 11th is this, 10th is this, because 9th is over here. So 9th, 10th, 11th, and the 12th. You can see this 11th and 12th are the floating ribs. Regarding ribs, also we have to understand. Now, in this particular slide, what is being shown is a thoracic cage, skeleton of the thorax. How to write in the exam, because just what we can say, will give you some idea over here. So when the question comes, apart from making the diagrams, including the labelings, be a bit systematic while writing answer in the exam hall. Like thoracic cage, anteriorly what lies, laterally what lies, posteriorly what lies. Like anteriorly we have what? We have the sternum and we have some costal cartilages. Laterally what we have, we mainly the ribs and the intercostal spaces, because between the ribs over here, between the ribs, this is what is known as intercostal spaces. So laterally we have 12 ribs, and do remember over here one basic point. Suppose this is rib number say 1, this is say rib number 2 over here. Okay, rib number 1 and rib number 2. Rib 1 is this. So this space over here will be called as a first intercostal space. First intercostal space. Similarly, if you go below, this is, imagine, rib number 5 and this is rib number 6. This space will be known as which space? This is fifth intercostal space. So how many ribs are there? Actually 12 ribs. So let us see the last space. So we have rib number 12 at the lowermost point. Just imagine above it we have the rib number 11. So what space is this? This is 11th intercostal space. So though we have 12 ribs on both the sides, but we have only 11 intercostal spaces. Remember this. Okay, that we'll discuss more. So sternum we have seen, a bit of ribs we have seen. Ribs, do remember that 11th and 12th below, you must be knowing, are known as floating ribs, 11th and 12th. The first 7 ribs are known as the true ribs because they are attached to the sternum. The 8th to 10th rib, the 3 ribs, they are known as false ribs because they are indirectly attached to sternum. And the last 2 ribs over here, 11th and 12th, are floating ribs. Basic. Okay, this is a basic thing that you should know. And you can even in this image, you can see which structure is this. That is attached to the manubrum sterni, clavicle. Do remember this. Apart from all this discussion of the thoracic cage and all, we should also know the clavicle. Now the thoracic cage posterior wall. So posterior, you can see the spines of the vertebrae over here. Posterior, again, you have 12 vertebrae, the disc and the ribs extending to the angles, the ribs which are coming to the angles. You can see the scapula over here. Just an idea how to write the diagram in the theory. Now, we have seen the sternum, the ribs, and a bit of vertebrae, but not in detail, but understood. We have seen the whole vertebral column. Now, thoracic cage. Cage, when we say cage is the bony structure. And when we say the thoracic wall, the wall includes the bony structure as well as all the structures lying in the intercostal spaces. That is the difference. When we say cage, cage is that bony structure or the osteocartilaginous structure. That is our cage. But when we refer to thoracic wall, it refers to the entire wall. Cage is a part of the wall. So the wall will have the bony cage plus the intercostal spaces. This intercostal space will have all the muscles over here and all the vessels and the nerves over here. That will all include the thoracic, the intercostal spaces, that will include the thoracic wall. The wall will also include the skin and the fascia outside. Are getting a point? The differences. Now here we are discussing thoracic cage. It will have an inlet, the upper narrower part. It will have a whole thoracic cavity, which includes the heart, lungs, and the other structure. And then it will have an outlet. This is the outlet. Though inlet and outlet are actually not pure terms. What do we mean by saying not pure terms? Because when we say inlet, it means that okay, everything is coming in. But what about the arteries from here, the carotid arteries? They're coming out. Just an example. So just for the sake we have used the word inlet does not mean everything is entering over here. An outlet means everything is coming out. But what about the IVC that is going over here? What about the IVC that is coming in? Just to give you an exception. So remember, this is for the sake of convenience. It is not a pure or a 100% true term. So we have an inlet, we have a thoracic cavity, we have an outlet. Simple. Let's go like this. Well, so if you have to answer about the inlet, then you have to answer in this manner. It is reniform in shape. Reniform in shape meaning by somewhat like this. AP diameter is 5 centimeter only. So this is 5 centimeter, while the transverse is quite huge. We have seen previously also, transverse is nearly double. This diameter is around 10 centimeter. Okay, what lies over here? This is the upper part of sternum. This is the upper part of sternum. What lies over here? That is the upper border of T1 vertebrae. And what will be on the side? Probably the first rib. Slope downward forward. Posterior end is 3 to 4 centimeter higher. But why is it higher? Remember, this was which notch? This was jugular notch. It coincided with T2 and T3 vertebrae, or the disc between T2 and T3. It means that T2 and T1 are above, so it are at a higher level. And this includes two vertebrae, that is around 4 centimeter higher. Okay. Boundaries now, the boundaries. So we have to, if the question comes like 2 number or 3 number question about the inlet of thorax, then you have to go with the shape, the diameters, how it is sloping, and how much high or low it is. Then you talk of the boundaries. Posteriorly, we have the upper border of first. Laterally, we have the entire first rib. So you have to draw it. And then here is a image just to, if you can sort of draw it, no problem about it. But basically, drawing again, I say, go step by step. Look at all the labelings. The question, this comes as a separate question. Structures passing through the inlet of thorax can come as a theoretical question where you have to enumerate 1 or 2 number marks, or can come as a detailed question of 2 or 3 marks. That's it. So if it is of 2 or 3 marks, try to make a diagram like this. But so this is very complicated, I know. You can take a screenshot and please focus only on labelings. Labelings. So what you have to make? Now see, here how to start with, either go from anterior to posterior or posterior to anterior. For example, let us see this. So this is T1 vertebrae. Okay. This is your anteriorly, you have to draw the veins. This is the internal jugular vein. Sideways, you have the subclavian vein, and they form the brachiocephalic vein. Anteriorly, the veins. Then if you go behind it, then comes the artery, subclavian artery, and here you will also have some branches of the carotid artery. Okay, and between them you can draw this muscle scalenus anterior. So scalenus anterior lies where? Scalenus anterior lies between anteriorly lying veins and the posteriorly lying arteries, and it rests on the first rib. Okay, then you can make out the trachea in front, and behind trachea you can make a or draw esophagus, just to show you what happens to the inlet of thorax. Okay, then obviously we have this pleura and the lungs over here. You'll see the cervical part of pleura rises above the level of even the clavicle. Okay, and you'll subclavian artery over here. Just focus on the labelings. 5, 10, 6, 7 labelings. Yeah, good to go. So again, we have seen the veins over here, and these are the obviously on the sides of trachea. You can make both of these common carotid arteries on the sides of trachea. So if again I say, okay, the question comes off structure passing through inlet. What are the important structure that you should not miss? Trachea, behind trachea, esophagus. Then vessels, try to make arteries, both common carotid and subclavian. Try to make the veins, jugular vein, internal jugular vein, and the subclavian vein. And obviously brachiocephalic vein. Try to make them. Behind, you can make the vertebrae, the thoracic vertebrae. These are the must structures. Then obviously between the artery and vein, try to draw the scalenus anterior. You are good to go. You will score good marks. Practice the diagram. That's it. Okay, this comes as a separate question because we have made question papers also. We know this comes as a separate question. Remember that. Then about the outlet, similarly as inlet, we talk about boundaries. Outlet is this lower part. So anteriorly we have this structure, posteriorly we have the obvious. Here comes the T12, sides we have the 11, 12 vertebrae. In the inlet, it was the T1. Here we have the T12. Okay, so just remember, this is how in point wise you have to give answer. Simple as that. These are slides for basically for that. Now here comes the lateral view of thoracic cavity. Lateral view, this is the anterior, that is the posterior. Try to trace this jugular notch over here, passing between T2, T3. Sternal angle passing between T4, T5. This is very simple to draw. This xiphoid process over here, intersecting the T9 vertebrae. That's what how we have to draw. You don't have to draw all of this in various, very beautiful, but see the diameter also over here is changing. So how you can draw it? Simply you can draw the sternum like this. Okay, with a horizontal line over here. Then over here, remember that when you are drawing the thoracic vertebrae, then try to remember, okay, this coincides around 9, so my lower end should be over here, and this coincides around T2, T3, so my upper end should be over here. Then with the anterior concavity, you can actually draw the thoracic vertebrae like this. and try to number them T2 over here. And remember, this will be T9. So you can fill 3, 4, 5, 6, 7, 8 in between like this, and 10, 11, 12. That is good to go. And here you can show, okay, this is the inlet, that is the outlet. How to draw it? Simple. That, okay, this is the inlet and this is the outlet. In between, you have the thoracic cavity. But remember, numbering, labeling is important. You should know what is manubrium over here, what is sternal angle, what is the body, which is this T4 vertebrae, T3. That is most important. If the examiner is seeing, okay, you are drawing everything correct, fine. If you have drawn a very beautiful vertebrae and the sternum and the labelings are wrong, then it is not good. Now about the sternal angle, why it is important? One thing which I told you already, which rib is attached to sternal angle? The second rib, yes. Don't forget this in your entire life. This will help you after decades also while counting the ribs. Because whatever stream of medical science you choose in your postgraduate degree or not, meaning by if you are plain MBBS also, whenever patient will come to you regarding any stream, you have to, if you are auscultating the chest, you have to even look at the ribs also. No, you should know that which rib is where. This the rib which you are touching is the 5th or the 7th rib. That should be clear. So now sternal angle, one thing is it gives attachment to the second rib. Then what are the other features over here? Here we have all the features, the importance of the sternal angle over here. So transverse ridge lies at the level of the second costal cartilage, that is done. This is the theory part, lies between 4th and 5th. Then comes the other part. Line of junction between two discontinuous dermatomes. Above we have the C4, below we have the T2 segment. So what does it mean? Don't get worried. Let me try to explain to you guys. See what happens is this is the sternum, okay, manubrium body. This is the second rib attached over here. Okay, second rib. So behind, if you go, then which nerve will be over here? Sir, T2. Very good. Okay. Which rib is attached? This is the first rib. Yes, very good. So behind, if you go, then which nerve is coming from here? Sir, T1. Very good. But do remember that we have done with the upper limb part, and I'm sure you are aware that C5 to T1 is dedicated where? To upper limb. So if you look at the lower part of the neck, we have the C4 dermatome over here, the lower part of neck. And then suddenly C5 to T1 goes into the upper limb. So after C4 comes what? T2, because C5 to T1 is gone into upper limb. So here the dermatomes are very important. That is being shown over here. Trachea, behind if you go, then trachea also bifurcates at this level. Not exactly at this level, but that is a theoretical thing. Let me just try to show you. The trachea actually comes down and bifurcates a bit below. But yeah, not very far off. So trachea will bifurcate over here. This is the importance of sternal angle. Other importance, see, beginning and ending of arch of aorta. So if we look at the arch of aorta, it goes like this, right? This is the ascending aorta. That is from here, the descending aorta. This is the arch. So this arch lies at which level? This is the sternal angle level. This horizontal level over here, this is actually our sternal angle. So arch begins and ends. Thoracic duct deviates from right to left. Remember that also. The thoracic duct is deviating from right to left at this level. Duct. Junction between superior and inferior mediastinum. Mediastinum we'll discuss in the next session probably, but although we have discussed it in our live classes, the mediastinum is actually the space between the two pleura. Okay, includes the heart. Anterior margins of both the lung and pleura approximate. Approximate means that they come close to this. The anterior margin of pleura and superior vena cava pierces the fibrous pericardium. So you can understand how many things are happening at the sternal angle level. You have to write them all. You have to draw the sternal angle and try to make a lateral view also. Just to show over here, suppose here the question comes about the sternal angle. No, here you can actually try to draw the heart over here. You can show the ascending aorta and the arch, and then the descending aorta. Okay, you can in fact, I'm just giving you ideas. You can in fact show this trachea going down and dividing into two bronchi over here. Okay, just use this image you can use while even discussing any of the topics. Okay, so this is about the thoracic wall. Let us move forward. Intercostal spaces. As we already saw that how many spaces are there? There are 11 intercostal spaces. Because the last space is the 11th rib over here and the 12th rib over here. And between them, we have the 11th ICS, intercostal spaces. Let us move forward. Right, this we have done. Each space is directed downward and forward. Narrow, no, intercostal spaces are narrow, meaning by the space is narrow posteriorly and anteriorly it is a bit wider. Why? Because the 11th and 12th rib guys are present posteriorly only. So we have more ribs posteriorly. While anteriorly, how many ribs reach? Only 10 ribs reach. But sir, why? Why? Because the 11th and 12th are floating ribs. They don't even reach anteriorly. Anteriorly, the last rib that reaches is actually 7th, but a bit of 8th, 9th, 10th, they go laterally. So therefore, it is narrow posteriorly and broader anteriorly. Think about it. This is the side view. Now showing about the talking of the boundaries of the intercostal spaces. So if the question comes about the intercostal spaces, you have to talk of the boundaries also. This is a which view? This is a lateral view. Here you can see the anterior aspect over here and the posterior over here, showing us any of the space. You can take any space. Anteriorly, we have the lateral border of sternum, obviously. Just imagine. Posteriorly, we have the vertebrae. What is lying above? Above is the sharp lower. This sharp word is very important. Sharp lower border, and below lies the upper border. But this sharp is very important. Why, sir? Why you are stressing on sharp? The reason I'm stressing on this sharp word over here is that this sharp lower border is known as the costal groove, and inside this costal groove runs the neurovascular bundle. What is neurovascular bundle, sir? Neuro is intercostal nerve, vascular is intercostal artery, intercostal vein. So this sharp lower border, supposedly, just imagine this small structure over here. This is imagine a rib. So above border, superior border is a bit smooth, it is rounded, but this lower border is quite sharp. And inside this sharp border, we have this neurovascular structures. We have this neurovascular structure. That is the whole point. Now, what is the inside the intercostal spaces? As I told, we have the muscles and we have the neurovascular bundles, nerve vessels. These are three things over here. Muscles are arranged in three strata. Question. You can't miss it. From outside to inside, if you go, you have the external intercostal, internal intercostal, and innermost intercostal. This innermost is a bit complicated. And in the innermost, we have these three subparts. But sir, why do we have three layers? Question should come to your mind. As I told my previous lectures also, every time the question why, see guys, why should be there? If it is why is there, then you have a good life. Life means every time why is very important. Anything is happening, you're studying anything, the problem comes why. Why this is happening? See, the reason this is, we have these multiple layers, is because these different muscles are arranged in different directions. Therefore, their actions are different. Because direction changes. Direction changes. For example, this biceps is going vertically like this. It will help in flexion. P major is coming transversely. It will help in adduction of my upper limb. Adduction cannot be done by the biceps. And flexion cannot be done by the pectoralis major, flexion of the forearm. So direction is a very important part. Similarly, when you will go to the head and neck part, the direction of the muscles of the eyeball, they are very important. The muscles which help in looking upward can only help in looking upward. They can't help in looking downward direction, right? So in this intercostal spaces also, these muscles have different directions or they have different actions as we'll see. And all these muscles supplied by different nerves and vessels that also we'll see. So in an intercostal space question comes, you start with how many spaces are there, what is their basic anatomy, how they are directed, where they are narrow and broad, and then talk of the boundaries, and then talk of the what is the inside the intercostal spaces inside. Just one example over here, talking of the external intercostalis muscle lying most outside. Understand the direction. Fibers are directed forward and downward, like this on both the sides. This is the direction of fibers. Like hands in your pant pockets or jacket pocket, whatever it is. This is the example showing us the external intercostalis muscle over here. Okay. Origin and insertion. This you can just goes from obviously the rib above, lower border of the above rib, and goes down below to the outer lip of the upper border of the lower rib. So there is just the read once or twice, you will remember. It's not very difficult or complicated. But this is the external intercostal muscle over here. This is the direction of it. And therefore, its action is a bit different. Okay. Other muscles. So what is the sternocostal? If you remember, it was a part of innermost. Where, sir? Here we have seen. Here. Innermost over here had three parts: intercostalis intimus, subcostalis, and sternocostalis. Sternocostalis lies anteriorly, subcostalis lies posteriorly, intercostalis lies on the sides, that is laterally. Okay, here you can see sternocostalis lying anteriorly because they are divided into different stratas. Okay, sternocostalis over here. Now about the just this was just an example, so that any muscle, if it comes separately, you know how to write the answer over here. Then, but the entire intercostal muscle, they are all supplied by what is intercostal nerve? These are thoracic spinal nerves. Don't worry about what is the spatial name, nothing. It is thoracic spinal nerves T1 to T12. Simple as that. Simple. Actions. Now, actions are different. That is why you have divided them into multiple layers. Similarly, we'll go for the abdominal wall also. This we are dealing with the thoracic wall, intercostal spaces. Similar structure goes in the abdominal wall also. It again will have 3 layers. So here, external intercostal does what? It helps in inspiration. Internal one helps in expiration. Okay, and innermost also will help in that way only. So what about the neurovascular bundle? Okay, where was the neurovascular bundle? Is everywhere over here. Nerve supply over here, and the vessels over here. They run between the second and the third layer. What was the second layer? Internal intercostalis, and the third layer was innermost intercostalis. So they run between the internal and the intimus or the innermost layer. In the costal groove, as I told, okay, the upper border of the rib is smooth, and the lower border is sharp. So inside this lower border, this is the costal groove. We have the neurovascular bundle. They are arranged in the structure of vein, artery, nerve. And when you make vein, artery, nerve, remember to make artery by the red color. Okay, remember to make the vein by the blue color, and don't forget to color the nerve by the yellow color. This is the arrangement of the structures inside the costal groove. This is intercostal vein, this is intercostal artery, that is intercostal nerve over here. Am I clear? Neurovascular bundle, very important. This is the arrangement. So this you can see the upper border that is a bit rounded. This is the sharp lower border. This is the sharp. This diagram you can easily make. I don't think it is very much difficult. And this part over here, this is the costal groove. And you can see the vein, artery, nerve over here. These are the muscles also being shown: external, internal, and innermost. And therefore it is said, it is not said, but it is a fact, that if you are doing if you are draining the pleural space over here, then don't insert the needle at the lower border, never. Because if you are inserting the needle over here, it can damage these structures. So either insert the needle at the middle or somewhere in near the upper border only. So these two areas are okay. But try to avoid inserting the needle at the costal groove, else you will damage this intercostal vein, artery, nerve. That is the point. That is another clinical scenario. You will see this more being scenario. A blood supply the intercostal spaces, arterial supply venous drainage, that we can do in another session, but I'll just make you go through it. Intercostal arteries are there. Each space will have 2 anterior and 1 posterior intercostal artery. Let me here the flowcharts will help you. Here, actually, what happens is when we talk of the anterior intercostal arteries, they are basically coming from internal thoracic artery. And this you can divide by upper 6 spaces and lower 3 spaces. Because anteriorly we have how many spaces? But sir, we had 11. No, anteriorly we have 9 spaces only. Why? Because anteriorly we have 10 ribs only. While if you talk about posterior intercostal arteries, posteriorly we have how many spaces? Up to you guys. We have 11 spaces. Therefore, when we talk of the posterior intercostal artery, or I write it as pica, they are mainly coming from the descending thoracic aorta, and they are basically divided into upper 2 and lower 9 spaces. Upper 2 is from other branches, lower 9 is from other branches. So remember to divide anterior arteries into upper 6 and lower 3. Upper 6 means upper 6 spaces is coming from a different branch, and lower 3 spaces artery are coming from a different branch. These upper 6 and lower 3 are upper 6 anterior intercostal artery, lower 3 anterior intercostal artery pair. Similarly, this posterior one has 11 spaces, so we divide it into upper 2 and lower 9. Let me show you over here. Okay, this is upper 6, that is the lower 3 over here. This names and the diagram over here. Similarly, for the this is the image over here showing us the anterior. This is about the posterior. So we have upper 2 and the lower 9 spaces over here. Upper 2 coming from the subclavian artery, and low 9 coming from the descending thoracic aorta over here. Diagrams are useful. Similarly, for the veins, just a name. If a question comes separately as our posterior intercostal or any intercostal arteries, no, try to name, not try, but actually write their branches, name all the branches. But sir, we can't remember. Therefore, look over here. Always remember few normal things, few things that can be placed everywhere. Okay, like we have the muscular branches, collateral branches, cutaneous branches, dorsal branches. They are actually sort of wherever the artery is going, think about, is it going to a muscle? Let me call it as muscular branch. Is it going posteriorly? Okay, dorsal branch. Is it supplying the skin? Okay, cutaneous branch. Is it giving collateral to any other artery? Yes, collateral branch. Okay, then anteriorly, if it will go, we have the mammary gland. Yes, mammary branches. Okay, then right bronchial. Now, what is this bronchial artery over here? This actually will supply the lungs. But the lungs will have pulmonary artery. Yes, it will have pulmonary artery also. And sir, why bronchial artery? Think about it. Guys, when we say about the artery supply of lungs, it is a dual blood supply. One set of arteries are the pulmonary arteries. They are for oxygenation for the entire body. But what about the oxygenation of lungs? But sir, does lungs need oxygen? Yes. When you inhale, the air is going, the oxygen is going inside those respiratory tree. But what about the tissues of the lungs? They also need oxygen. Who will provide them? Bronchial artery. So second set of artery is the bronchial artery. Understand? And it is coming from where? From the posterior intercostal arteries. Why? Because they are coming close to the lungs. We're getting a point. So lungs have a dual blood supply. One is pulmonary artery or pulmonary circulation, pulmonary set of arteries. One is a bronchial set of arteries or bronchial set of veins. When you use arteries, you have veins. So try to remember the branches also. That will help you in writing the answer over here. And if you make a diagram, then nothing like that. Here you are seeing the thoracic aorta dividing the giving out the dorsal branch. These are the muscular branches. This is skin, that is cutaneous branches. Okay, perforating branches are the other branches over here. Perforating branches are the ones they will go to the mammary gland. Venous drainage, we have intercostal veins, posterior, anterior. These are all the posterior intercostal veins. This will discuss tomorrow in detail, but here is a diagram. I urge all of you to actually practice the azygous venous system diagram at least. Azygous venous system diagram is very important. And this is all the different sides, right hand side and left side, where they are draining. These are all posterior intercostal veins, not arteries. This is a azygous venous system. We will talk about this again tomorrow. Today we have other topics to discuss. Yeah, a bit of applied anatomy for the intercostal spaces. In intercostal nerve block, what is this nerve block? Let me use a highlighter over here. In nerve block, anesthesia is injected beneath the. Now here here it is written, it is injected beneath the inferior edge of the rib. But sir, you just said 5 minutes back that don't try to touch on the inferior border. But here, because now guys, when I said at that point, I meant to for the pleural tapping, to take the fluid or the blood out from the pleural space. Here you have to itself block the nerve. So you have to reach close to the nerve. And where was nerve? Deep to the costal groove. So you put your needle close to the costal groove. That is the inferior border of the rib. That is the point. Now, pus from the region of vertebrae takes the course of the intercostal nerve. Okay, obviously. So that comes in basically in previous when the TB was very rampant, tuberculosis. Okay, here's the image to show you all the 3 sides of the exit of the nerves over here. Okay, here the syringe and the needle has been shown to you guys. This is a which image? This is a, we can say which sort of section is this? If I may ask you, try to think. This is which sort of section? Is it a transverse, sagittal, or a coronal section? Let me help you. This is the rib over here. These are the lungs already labeled. This is the skin already labeled. Now think. This is a parasitical section. Understand the diagram first of all. Parasitical section, because once you understood, then only you can draw it. This is anteriorly and that side is lying posteriorly. So if you go from anterior, you will see the skin, you will see superficial fascia, then you will see a muscle over here shown as serratus anterior. Okay, it's the upper limb muscle. Then you have 3 muscles in the intercostal spaces: external intercostal, deep to internal, and most inside lying is the innermost intercostal. I'm sure not shown over here, but yeah, it is somewhere over here. And these are your ribs. These are your ribs: above rib, lower rib. lower rib. And between them, if I may try to show you what is this structure, this is the costal groove. There's a red color. And deep to it lies blue color vein, artery, and this yellow color nerve vein. Okay. And deep to it, you have transverse thoracis, and obviously you have the both pleura and the pleural cavity. Remember, the thoracic wall is only up till parietal pleura. So thoracic wall, if suppose a question comes, it comes in more than a PG MCQs, but thoracic wall, if the question comes about the layers, start with skin, superficial fascia, deep fascia, similarly as pectoral fascia. Then you can name some muscles over here like P major, as I told, or serratus anterior, depending on anteriorly or laterally. Then you can talk of external intercostal muscle, internal intercostal muscle, and innermost intercostal muscle. Okay. What after that? After that comes the endothoracic fascia. Endothoracic fascia. Okay. This transverse thoracic. What is this transverse thoracic? It is a part of innermost intercostal. What is innermost intercostal was the third layer. It was third layer. So you can see that between there's a second layer, that is first layer. Between the second and third, if I just try to highlight it, give me a second. So where was the neurovascular bundle lying? Between the second and third layer. So this transverse thoracic is actually a part of third layer. Okay, coming back to the layers. So we had this uh, in innermost intercostal. Then we have endothoracic fascia. END is endothoracic fascia. And finally, we have the parietal pleura. So actually, guys, this from skin to parietal pleura, this is our thoracic wall. And what is the relevance of it? The relevance is that entire from skin to parietal pleura, it is all supplied by intercostal nerve. That is thoracic spinal nerve. Remember that. Okay, if we move forward, we come now to the pleura. What is pleura? That is what we can say, the coelomic, the epithelium lining the outside of the lungs, pleura. Here you can see the pleural cavity. So if a question comes up pleura, try to make a diagrams over the lungs and pleura, and then try to divide the pleura into two, parietal and the visceral pleura. Even you can talk of their embryology also. The pleura question comes, you are dividing the pleura into a parietal and a visceral pleura. What about their embryology? Can we discuss it? Yes, of course, why not? Because we are talking of differences. Embryologically, this is coming from the somatic layer of lateral plate mesoderm. This is coming from the splanchnic layer of the lateral plate mesoderm. Their whole embryology is different actually. Therefore, this is a part of thoracic wall. Therefore, it will be supplied by intercostal nerves. But this is actually, it forms a part of the viscera. It forms a part of viscera. Therefore, its nerve supply is not intercostal nerve, its nerve supply is autonomic nerve. Therefore, if I ask you which pleura will be pain sensitive, this one will be parietal, will be pain sensitive, because pain sensitive means is our skin pain sensitive? Yes. So when the nerve is supplying, the same nerve is supplying the skin and the parietal pleura, then obviously it becomes pain sensitive, and this becomes pain insensitive. But sir, will it not have any pain? It will have pain mainly during ischemia or dilatation or stretching. Okay, when we have stomach ache, no, it is mainly due to stretching of the stomach, excessive peristalsis. So it will be pain insensitive, but it will have the discomfort, a different type of diffuse pain, only towards either ischemia, that is the loss of blood supply, or stretching or distension only. Remember that. Basic differences, though you'll see more. So here is the pleura, and obviously the recesses over here. Pleura, yeah, few points over here, delegated close to serous sac over here, very good. And embryologically, lung invaginates it from the middle side, has two layers, has a potential space that is known as pleural sac. This is the image just to show you how the initially embryologically this lung bud over here, how it invaginates the pleura from inside, and therefore what actually comes around is your two layers, the visceral pleura and the parietal pleura, and between them you have the pleural cavity. And this highlighted or the blackish area over here, that is actually the lungs tissue. It is a viscera over here. That is the lungs is the viscera over here. Okay, lung bud invaginating to pleural sac. We already seen this. This is the difference. Try to make a table also in the exam, all guys. A small question comes of pleura, even of two numbers. Try to write these 2-3 lines over here, and then try to make this table job done. And obviously, without a diagram, I won't say job done. Try to make a small diagram over here. No, that is not no big deal. Just to show you just to show the examiner the difference between the visceral and the parietal pleura. That's all. Let's see differences. Outer layer, inner layer, developed from this embryologically. It is divided into four depending on the part it lines. So it is not divided into four, it is named into four. Okay, we can't say it is divided, it is named, it is classified. It is a continuous layer. So the pleura that is inside the ribs, we call it as costal pleura. The pleura that is touching the diaphragm, we call it as a diaphragmatic pleura. The pleura that is reaching the neck region, we call it as cervical pleura. And the pleura lying medially, we call it as mediastinal pleura. Okay, last couple of differences. Supplied by somatic nerve, therefore pain sensitive. Nerve supply is same as lungs, that is the autonomic nerve. Autonomic nerve. And therefore it is pain insensitive, simple as that. Yes or no? Try to remember this. Then obviously parietal pleura, we have seen it is divided into four parts or named into four parts. Neck region, cervical pleura, underlying the ribs, costal pleura, mediastinal pleura, and below you have the diaphragmatic pleura. And this diagram also try to see that this green color is the whole parietal pleura, while this black line over here, let me try to show you, this is actually what it is, the lungs being overlapped by the visceral pleura. Therefore the space between them, all this space, let me, if I may use a different color, this whole space between them, this is what, that is the pleural space or pleural cavity or pleural sac. Yes or no? This all is pleural space or pleural cavity over here. And here comes a couple of recesses over here. Costodiaphragmatic recess. That is between the costal pleura over here and the diaphragmatic pleura over this space over here. This space over here is known as costodiaphragmatic. That is clinically very, very important. But sir, why? Why it is clinically very important? Because it is due to gravity. Whenever there is any fluid accumulation, let me show this blue color, any beginning of fluid accumulation over here, by gravity it will fall down and start to accumulate over here. While doing an ultrasound, even an ultrasound after the accidents, we do a fast ultrasound. Fast means focus assisted sonography. So when you are doing ultrasound on and even a simple chest X-ray, you look for this part. If it is normal in an X-ray is what? Normal in an X-ray is when it is like this, that is normal. But if this part is blunted like this, then obviously there's some fluid that is being collected over here. So blunting of the angles, we call it as in X-ray report, a blunting of the costodiaphragmatic angle. That tells us, okay, that there's some fluid over here. That even can be seen in ultrasound. Ultrasound is actually dependent on the radiologist skills. X-ray you can easily see, ultrasound also you can see. So that becomes clinically very important. A minute amount of fluid, be it pus, water, be it your blood, with gravity it will fall down and accumulate over here. That is costodiaphragmatic recess. Why we call it as costodiaphragmatic? Because this part is a diaphragmatic pleura. This is the costal pleura. Then there is costomediastinal recess. One more recess is there, known as costomediastinal recess. What is that? This part is the mediastinal pleura. Okay, so this recess over here, that is the costomediastinal recess. But clinically more important is costodiaphragmatic recess, because gravity wise it is lower down. Okay, so try to make this and talk of recesses in the pleura question. Okay, this is just to show you the what are the anterior margins of the pleura. We have this reflection of the pleura over here. This is very important, guys. Inferior leaves, you can see it. Go to previous images. Inferior leaf, you see, when we have this gap, that is actually differing at that is actually switching to different levels. That is being shown over here. This is the anterior aspect. That is the posterior aspect. In between, you have the lateral aspect over here, down over here. So until if you see related to the sternum, the lower border of the lungs or the visceral pleura lies at which rib? It lies at sixth rib, anteriorly, sixth rib. While the lower limit of this pleura, when you say pleura, we mean parietal pleura, lies at eighth rib. So there is a gap of how many ribs? Two ribs. If you go laterally, that is in the axillary plane, it is eighth and 10th rib. If you go behind posteriorly, we have 10th and 12th rib. So there's always a gap between the lower margin of the lungs and parietal pleura. That is PP parietal pleura. This is lungs oblique VP visceral pleura. That normally or nearly always there is a gap of two spaces over here. Why there's a gap? Because when you will inhale deep deep inhalation, deep inspiration, lungs will expand. They need spaces to expand. Else, where will they expand? If below you have this whole diaphragm that is just below the lungs, we say na diaphragm is below the lungs. We say it, but actually diaphragm is below the parietal pleura. So if the diaphragm comes over here, and it does not go down with inhalation, then how will the lungs expand? They need these spaces. Okay. Okay, and there's one more term known as the Simpson's fascia. What is Simpson's fascia? That is actually your fascia that is covering the cervical pleura. So this part over here that is covering the cervical pleura, it is known as Simpson's fascia, also known as suprapleural membrane. And do remember that questions have come regarding its attachment. So apex is attached to the C7 vertebrae. This is the whole. Let me use a highlighter over here. Will be, I guess, a bit better. This is your Simpson's fascia, suprapleural membrane. Its apex is going above. It's attached where? Yes, right over here. That is C7 vertebrae. It covers up the lungs, the apex of the lungs from above. Okay, it will slightly limit the all expansion of the lungs. But above, we have a neck space also. Okay, nerve supply pleura. Again, a question. Do you remember the nerve supply? Parietal pleura, as I told you, intercostal nerves. Okay, intercostal nerves, which are what? Which are thoracic spinal nerves. But if you talk of this mediastinal pleura, no, that is medially. So phrenic nerve is actually passing, and the phrenic nerve will supply it. That is C3, C4, C5. And diaphragmatic pleura is the lower part of pleura. Okay, intercostal nerve will play and a phrenic nerve. So regarding parietal pleura, you will never see any autonomic nerve coming. What autonomic nerve? Sympathetic, parasympathetic. Here you have the intercostal nerve, thoracic nerves, or the cervical nerves. Cervical nerves, the phrenic nerve. So when it is passing through the medial side, then it will supply that part. Blood supply pleura, again, arterial supply, you have this, just remember them. Don't worry, just guys remember read for 2-3 times. Things will become clear. For example, costal pleura is lying outside. So outside we have the intercostal artery. Why? Because this artery was supplying the intercostal spaces. Then you have the mediastinal pleura lying on the inside. So this artery runs along with the phrenic nerve. Pericardiophrenik artery and the musculophrenic artery, these both they run along with the phrenic nerve. So when these two nerve supply was coming from phrenic nerve, artery supply come from there. Above, if you talk of this, then you have cervical. Because cervical artery is close to cervical region. Venous drainage goes to these couple of veins over here. Lymphatic drainage also, let us see that too. Lymph drains to basically your costal, mediastinal, diaphragmatic pleura, just the them ones. A pair of lymph nodes where the lymph will drain to. Then visceral, if you're talking about visceral pleura, then here this thing will change, Arterial and fine, they're fine. Because visceral pleura is close to the it acts like a viscera. Its embryology is close to the viscera. Viscera means we are dealing with some structure related to endoderm. So here you see even the arterial venous drainage, they are the ones which are supplied like the lungs only. Because the visceral pleura is sort of glued or it is sort of fixed to the lungs. So if a artery, logically think, no. If an artery is supplying the entire lungs and there's one layer which is fixed to the lungs, so why will not that artery supply that part also? Will definitely supply. But will this artery reach the parietal pleura? No. Why? Because between this artery and the parietal pleura is the pleural cavity. Does it make any sense that the artery is crossing the pleural cavity? No. Right? So it won't be reaching over there. Same for the nerve supply, same nerves supplying the lungs. Same nerves. Recesses, potential spaces, as we have seen already, two recesses mainly over here, which is clinically important. Costodiaphragmatic, more important than costo-mediastinal recess. These are the 3 levels that we have seen. So just an idea how to write in exams, guys. Make a table like this. The 3 levels of the mid-clavicular line, that was lying anteriorly, mid-axillary lying laterally, and back means posteriorly. So remember, it was also very simple. How to remember it? Just remember 6, 8, and 10, and add a 2 over here. 6 plus 2 is 8, 8 plus 2 is 10, 10 plus 2 is 12. Simple as it. This diagram will help you. Costo-mediastinal recess. Its role is not as significant, but you should know at least what is the CMR, costo-mediastinal recess. It's the space between the costal and the mediastinal pleura. Okay, that was where we have seen already. This image also, we have seen the syringes going, and this is known as paracentesis thoracis. Now here we are not giving the intercostal nerve block. No, not this. If you have to give this nerve block, then your needle anesthesia should reach where? Close to the nerve. No. Therefore, while giving this nerve block, when do we give nerve block? When there's a rib fracture, there's too much of pain in inhalation or in respiration, then we give nerve blocks, mainly in rib fractures. Then you have to go at the lower, but all other cases, these are much more common. The other cases are much more common. We have to go close to the upper border. Okay, that is known as paracentesis thoracis. Needle inserted close to the upper border of the rib in the lower part of the space to avoid injury to neurovascular bundle. That was what we have seen. We have been discussing. These are all the other relevant applied anatomy. Just few diseases over here. Just imagine. Just let me tell you. There's a whole department, TB chest department, that is related to this particular organ. So there's a whole department. There's a 3-year MD and a 2-year DNB mainly for that only. So there is too much applied. But just for the beginning, you should know this. When to name what. Okay. Then we lastly come to thoracic abdomen diaphragm, that we'll discuss tomorrow, guys. The diaphragm over here. The diaphragm, it's a common topic between the thorax and the abdomen. So what we discussed today is the thoracic cage, the thoracic wall, how to write about it, about the pleura in detail. Okay. And about other structures also relevant to it. But remember this external angle and all sort of question that we have seen. Let me go back quickly. Give me a second. These are all the slides that we have sort of covered. Let us see how many, just I have seen how many sort of questions that we have tried to touch upon. So thoracic wall over here, a bit in detail. Diaphragm will complete tomorrow. Vertebrae ribs, the pleura over here. Okay. Intercostal muscles, sternal angle, and the recesses. Right. So tomorrow we'll talk the diaphragm, and tomorrow basically some coronary circulation, the heart anatomy. Coronary circulation, the diaphragm, and a bit of heart anatomy or the mediastinum. We'll discuss it in the next session, probably tomorrow. Okay. Any doubts, let me know. All the best, guys. And thank you. See you tomorrow soon. Bye-bye. Take care.